Good afternoon, everyone. Welcome to the bi-monthly webinar of the Geriatric ED Collaborative. As everybody's filing in from the waiting room, we hope we didn't keep you waiting too long. I just want to say a hearty welcome to all. My name is Dawn Milady. I'm an emergency doctor at Mount Sinai Hospital in Toronto, Canada, and I'm a core member of the Geriatric Emergency Department Collaborative. And I'm joined today by a wonderful group of experts. The topic today is Geriatric Emergency Management Nursing. And interestingly, this is the only webinar that we are repeating for a second time. We did it first probably 2 years ago. One of the issues with the topic is that it has so many different names, and many different names are used around the world. So we've Geriatric Emergency Management Nurse, or GEM, Geriatric ED Initiative Nurse, GEDI, Geriatric Resource Nurse, Geriatric ED Case Manager, Quick Response Geriatric Nurse, Geriatric ED Care Coordinator, etc., etc. For simplicity, we have decided to just use the term GEM Nurse because we know that by whatever name you call that role, they are definitely GEMs. Next slide, please. We asked you in advance when you registered about your experience with the GEM nurse role, and we got a lot of a range of responses. Now, 196 people signed up for this. We've already got 100 on the line from 12 countries around the world. So next slide, please. These are, I just grouped very unscientifically some of the responses we got. The boldest ones were the ones that came up the most. So things around transitions of care, coordination, advocacy, education, leadership, then screening using both general and specialized assessment tools, supporting families and other caregivers, identifying needs and issues beyond the medical, including the medical, but beyond it too, building bridges with home-based care and other community care. And then sort of sadly, floating over there on the right in small print is the one called building capacity. And I think all four of our experts today are going to have a thing or two to say about that. And that's the whole issue of not just doing the job, but creating the job, expanding the role, doing all the footwork that it takes to make the job function well. We've got a very diverse audience on the webinar today. We've got folks calling in from Canada, the United States, almost all 50 states, Canada, Ireland, Switzerland, Italy, Belgium, the Netherlands, Australia, India, and Malaysia. And a special shout out to our Malaysian team, because as far as I know, it's 3 in the morning there. So that shows dedication. Next slide, please. The Geriatric ED Collaborative is a network of both community and academic EDs working together. We define best practices in geriatric ED care. We're in the business of educating clinicians and administrators about models of care, which is part of today. We support emergency departments and healthcare systems as they implement some of those models of care. And then there's a large wing that does research and evaluation of outcomes. Next slide, please. So if you want to be more involved with the GEDC, and it doesn't cost you anything at all at the moment. So if you want to be on our mailing list, get our newsletter, get full access to everything that's on the website, please consider joining. You can scan the QR code there. You can simply go to GED Collaborative and click membership. We would be very happy to have you among our members. Next slide, please. The GEDC is generously supported by the John A. Hartford Foundation and the West Health Institute, and we couldn't do this work without them. Thank you very much. Next slide, please. Just so that you're aware and want to revisit, this webinar is being recorded. It will be on the GEDC website within a few days, certainly within the week. You'll get the transcript of the chat, you'll get the live cast, and you'll get notes as well. And while if you want to visit the site, you might want to check out some of the other on-demand webinars. We're now getting close to 30 webinars over the last 3.5 years. We also asked you a question when you registered, what other things would you like to learn about? And as I scanned that list, which I won't go through, I noticed that many of you said you would like to learn more about things that we already have excellent webinars on. And that information doesn't go stale, and those experts don't lose their glitter. So there are a lot of things there. Telemedicine, interdisciplinary care, making the financial case, delirium screening, education, frailty. There's a lot of material that is available to you. So next, next slide, please. So as we get started, we have a very simple poll for you. And that's just to know who works in a place that has this GEM nurse role available to them and who does not, and do you know or not. Next slide, please, and we'll get back to the answers in a moment. We have a fantastic expert panel with us today. I'm going to go in alphabetical order. Nana Asomaning is an advanced practice nurse with certification in geriatrics. She's currently the ED patient care manager at Mount Sinai Hospital in Toronto, if that may sound familiar to you. Before that, she was the GEM nurse in our same department for 10 years, where she largely created the role, and then has been the manager of the acute care of the elderly unit in our hospital. And she's otherwise known as the woman who's been telling me what to do for the last 15 years, and to whom I credit all of my success. Aioife Dillon is a geriatric nurse practitioner who's currently working with Home First, a specialist older persons team in the emergency department of St. James Hospital, Dublin, Ireland. She's worked as a geriatric nurse in acute care and ambulatory settings for nearly 20 years. Pam Martin is a nurse practitioner with certification in geriatrics, with 10 years of experience in geriatric emergency medicine. She also is a core member of the GEDC faculty, and she works currently at the Yale New Haven Health System to promote geriatric ED care. And finally, Michelle Moccia. Both Pam and Michelle have been on several webinars. Michelle developed and led for 12 years the first senior ER in the state of Michigan, which eventually went on to become a level 1 geriatric ED. Now, I'd just like to point out that I did the math, and collectively between these 4 people, we have 114 years of nursing experience, most of it in the ED. So if you're starting a GEM nurse role, or you want some tips on how you can do things better, this is really your opportunity to ask an expert. I notice there are a lot of GEM nurses on the call, so I'd urge you to text in questions that you have, but also tips and tricks and suggestions. And please don't wait until the end when we run out of time, but if you can keep those questions and comments coming in through the webinar, that would be great. That's enough of me. Can we exit the slide and go to full screen? Oh, I'm sorry. Before that, I didn't have a chance to see the poll answer. Thanks. So more than half of the people here work in a site that does have a GEM nurse role. A third don't, and nearly 10% or around 10% are not sure. They can't have been to their emergency department recently if they don't know whether there's a GEM nurse around or not. Okay, thanks. Now can we exit the slideshow? So I'm going to start with just a quick go round of our various panelists. Nana, what are some of the things that you've done to create the role at our hospital? I've seen you doing it. What are the most important things that you have done, and what has worked particularly well for you?
Thank you, Don. So I think starting with some of the things that I've done in the role, and there's quite a big panel here, so I'll try and stick to just a few key points because I'm sure other people have lots of other great things to share. But I think one of the key things that I've done when I was in the role is case finding. So case finding involves walking around the different areas in the emergency department, having conversations with staff, both about the acuity of the patient, what's going on with the patient, but also how I can support a geriatric lens. I think this works well in a twofold way. A, it's bread and butter, it gives you business, but also in doing that, it builds credibility. People having conversations with you have a lot of aha moments, and that what you add to the case, what you add to that patient's disposition in the department. And then with case building, or with that builds buy-in, and so people trust you and in having those conversations because of all those aha moments. And so with the case finding that builds into your buy-in, then what I found has worked well overall is the ability to then spread that like wildfire, because people then see you coming. And by the, many years into the role, people knew I was coming and were ready with things to tell me, assessments that they had already initiated. And so that was one of the key fundamental pieces: case finding, day-to-day, boots on the ground with staff or anybody who's willing to talk to you about the patients in their area.
Can I just ask a question, Nana? You keep using the term everyone. Are you talking about nurses mostly, or whom
Yep.
were you building on?
So everybody who would listen, there were nurses, student nurses, staff, attendings, residents, pharmacists who may have been called into the case to do a review of the medications, social workers. In the early stages of the role, there's often the tension that lies with overlap. And so case finding with your colleagues, recognizing that you come to the case with similar lenses, but very distinct lenses, also helps to bridge the gap in building trust with your colleagues. So everybody.
And then the spreading like wildfire, what are some examples of that?
So that involves case finding at the local level, as I highlighted, but also going to different committees and sharing those key cases or key clinical cases, but also bringing that geriatric lens to these different committees. So you might have a falls committee, but also identifying the unique challenges of falls management in the ED department, and bringing that lens as well. And so continuing to spread that, and then people getting used to you being the voice and the lens for geriatrics from the emergency perspective, which is unique from the perspective from an inpatient world.
Yeah, so before we move on to Aoife, I just need to say that Nana was phenomenal at that. And in fact, it's from her that I learned the term capacity building. So not only did she see seemingly every older patient in our emergency department with her colleagues for 10 years, but constantly working on building other protocols, processes, sitting on committees, creating order sets, working on with other departments of the hospital. So it really, that's another thing that really builds the role. Thanks, Nana. Aoife, what can you say about your, how you got things started, what things work really well for you, what's important?
Well, it's important to understand that I'm part of a 4-person team. So our job, it's myself along with a social worker, a physiotherapist, and an occupational therapist. And our job is to provide holistic specialist assessment of older people presenting to the emergency department. But the aim of it is to provide alternatives to admission. So it's not just seeing older people who present to the emergency department. It's about facilitating their safe discharge. So especially for the patients living with frailty, we don't want them to be admitted to hospital unnecessarily. They become more unwell in hospital, they decondition. We tend to discharge them more dependent than when they came in. So our job is to try and prevent that for the most complex, frail older people. And this means doing, a complex assessment on the day at the time with the patient. And it often means we need to put in place complex support structures or follow-up referrals that are needed for that patient on the day. So we work very, very closely with everybody in ambulatory care in the hospital. We work with our colleagues in the community in primary care, voluntary services, and we tend to need answers from our colleagues right then and there about whether or not they can support our patient. They can take a referral and support this person to get home. And it's really important that we work alongside our emergency colleagues. So we are never instead of the emergency department. The emergency department and the emergency staff are experts in what they do. We all are coming to the emergency department with our geriatric competencies, and we are an addition to their usual care, so that we're complementing and improving their usual care. And how we got started was to just get, as Nana says, get boots on the ground. We had to go down, find patients. Nobody really knew what we wanted to do, didn't know how we were going to go about it. And to be honest, until we started, we didn't either, but we just had to go to the department and start seeing patients, go to the staff, say, we're here. Trust us, we won't make your life worse. We really do intend on making everybody's life better. And we just found older people in the emergency department. We accept referrals absolutely from our colleagues, but we don't wait for referrals. When people are triaged over 70, we go and find them and talk to the patient themselves. Why are they really here? Has there anything been missed in triage? What matters most for this patient today? What do they want to get from their visit to the emergency department?
Thanks, Aoife. Great points. And you addressed some of the questions that were already coming in, triggered by Nana. And I'd urge everybody on the chat to read Nana's responses. And both Michelle and Pam, maybe you can comment on the questions too about who should the GEM nurse see, all older patients or older patients going home, and the technical one about does the GEM role at your place link to the EMR? So that'll come up. Pam, please tell us about, you've had an interesting career. You were a frontline GEM nurse in an emergency department in a larger academic community hospital, and now have gone on to a more, even more senior role in a large academic setting. Can you tell us about the two different experiences that you've had?
Sure. So at my previous hospital, I came in with a program that they had kind of already decided how they wanted their program to be. And so I came in as an employee of our emergency department. So our emergency department physicians who were contracted physicians for this particular hospital. At that particular time, I was hired to do primary emergency department medicine on geriatric patients. So I was going to be the emergency kind of department person for our geriatric patients and doing the medical workup.
Do you mean that like you were responsible for all of their care or the extended assessment?
All of their care is how it's how it had been set up. My medical director and I decided very quickly once we started seeing our geriatric patients. I did not have an ER background. Let me preface with that. So I did not have an ER background when I came into this role. And my emergency department collaborating physician did not have geriatric experience other than just seeing geriatric patients in the emergency department, but no real kind of extra geriatric knowledge. So as we were developing our program and seeing our patients in that kind of respect, we learned very quickly that this was not a role that you could do the medical management and the geriatric management at the same time, because you quit those geriatric principles quickly went out the window when you were trying to make sure you didn't miss an emergent diagnoses. So we changed it into a consultant role. And that's how it stayed for the 9 years that I was there. So a consultant role, having that extra set of eyes and ears going into the patient and having conversation with patients and family. I had the time that the emergency department physician and staff did not have to be able to gather additional information and to gather, call the nursing facility, call the family, figure out why the patient was truly there, and and a lot of times find mistakes that we had missed, or not even in conversation, or to be able to add on to the assessment and treatment plan, based on the additional information that I was able to gather. So we were able to catch things quickly and make sure we were treating the correct problem. I can give a quick example of that. I had a patient coming in from a nursing facility, they were in long-term care, came in apparently for abdominal pain is what it said, but and so the physician had seen the patient, they had started the abdominal pain workup. I walk in, the patient was basically unresponsive and there she came from a skilled nursing long-term care, so of course it said dementia in the chart, so everybody thought she was totally demented and couldn't but when I called the facility, they were like, no, she's she has dementia, but she's normally alert and oriented ×3, and she didn't come in for abdominal pain. She came in because she had missed 3 dialysis sessions, and that so it totally changed their workup, because her K was like 7.2, and and she was obtunded from that, so needed to get emergent dialysis. So having that extra set of eyes and ears go in and take a look and kind of put the picture together was very helpful.
Yeah, thanks, Pam. I think you make a really important point with a great story to illustrate it. That everybody on the call probably, particularly starting into the role, needs to make a decision about: is this role just another clinician who can diagnose pneumonia and start antibiotics, or is this an added value thing, something that a person who is doing other things that are not already being done by a physician assistant, a nurse practitioner. And I think the places where GEM roles have had the most success are the ones that you guys are talking about already, where the person is doing things that other people don't have time to do, or don't have the skills or knowledge to do. So Michelle, moving on to you, tell us a little bit about your experience at the hospital that you led for so long.
Great. Thank you very much. So I was fortunate to be at the right place at the right time. I call these moments divine intervention and or the luck of the Irish, since we're also speaking to somebody from Dublin, Ireland. So what happened, I had recently graduated with my NP degree in 2010, and lo and behold, our hospital decided to create a senior ER. And that was based on one of our sisters' hospital in Silver Springs, Maryland. And so we decided to do that because, looking at our community, about 1/3 of our population that was coming in with older adults. So we didn't have any templates or guidelines, because the guidelines didn't come out till like 2014. We created a 6-bed unit. We asked nurses in the department who would like to work in that 6-bed unit. It was going to be a 2-to-1 ratio. We came up with assessments around the geriatric syndromes. We decided to use, there was a tool, identification of seniors at risk, which everybody knows, ISAR, and there was also the TRIS tool, the triage risk screening tool. We decided to do that. And then in the 6-bed unit, we knew we weren't going to be able to get everybody to rotate in and out in 24/7. So the nurses then that were working in the unit, their responsibility was, when they were done, because remember, they had a 1-to-2 ratio now, they were to go out into the ER and help the other nurses with these assessments. So so over time, what happened, we didn't realize that this was the best thing to do, to train all our nurses to do these assessments, because about 4 years later, we increased our ER size, doubled our capacity. But what we did do is that when we were learning from everything that we're doing, and we are constantly that was my job as the program director, to really look at it and get the input of the nurses, is that we built in triggers so we could have referrals go to PT, OT, dietary, to social work, to case management, so we could offload them. So our model was not just one person, it's all the nurses that do these assessments for 65 and older, and it has served us well. It takes each nurse about 7 minutes to do an assessment, but we also have exclusion criteria too. If someone comes in with airway, breathing, circulation problems, having a stroke, they're not going to get this assessment, right? Because you're there to save their life.
Yeah, so I think this is an important message also, that there are many, many different models of geriatric emergency management nursing. And it's surprising the number of sites around the United States and around the world that have opted for that, training up all staff to have additional expertise and knowledge in geriatric assessment, with a single, maybe more administrator role, is what you're describing, as opposed to what I think Nana, Aoife, and Pam have been talking about, where the geriatric nurse management role is actually on the floor and seeing patients, but in a very specialized sort of way. Aaron, you've been watching the chat closely. Any questions?
Yeah, a couple things. One, thank you for all these questions and the panelists answering. Been some great back and forth, which is wonderful. I just have to say one thing that's near and dear about the role of these nurses. I forget the individual that said that I have to tell people I'm a maxi nurse, not a mini doctor. So as a nurse, that's near and dear to my heart. That said, a question, I know Aoife and others have started to address this, but I think Marlene asked about 24/7 coverage. I'm assuming most places are not. If not, how are you addressing off hours versus on hours? So maybe potentially go round robin with that.
And even add a rationale for not being 24/7. Nana, do you want to start?
Yeah, I can start. So at Sinai, we developed what was called the specialized geriatric services. And it was essentially a sheet that people could fill out. And I believe we used the ISAR and some other indicators as a tool. And so if you're seeing a patient at off hours, whatever that looked like, and you think they might benefit from GEM engagement, people would fill it out, stick a sticker on it, and then put it in our little slot. And then as GEM nurses the next day, or usually within 2 to 3 business days, we would call that patient. Often, like half the time, it was around support, counseling, follow-up, but even giving them direction as to their ED visit. But sometimes there were some very real concerns, things that maybe weren't picked up or flagged in a timely fashion in the emergency department. So it was definitely an invaluable aspect to the role. And I think it also gave people that appreciation that there's always something that they can do, because we found that with this piece and in speaking with people in the emergency department, people want to help, and they can see that the help is wanted by the patients. But as an emergency nurse, so many competing interests, such a focus on high acuity patients, they didn't always feel that they could do anything. And so the addition of the SGS referral really gave people that, almost power and autonomy to say, this person needs more than I can offer them right now. And then we would just follow up in 2 to 3 business days. So that's what we did at Sinai.
Thanks, Nana. Pam, Michelle, or Aoife, this is a common question, often a kind of a negative one. Oh, well, they're not there all the time, so how can they be that important or valuable? I can't think of a single hospital in the world that has GEM nursing available 24/7. What do you say about that, Pam?
Don, we actually looked at our arrival times and discharge times for our older adults, and they were there pretty much started coming in between 9 and they were there, until about 11 o'clock at night. But we also looked at our community resources and when we would be able to discharge our patients back into the community. And at that particular time, it was like around 5 o'clock. It's kind of was like our cutoff. So our staff actually worked and our focus at that particular hospital was on discharge patients being discharged back into the community, whether that was, back into their home, which was long-term care or skilled nursing or assisted living, or actually, home in the community. So whatever their home was, getting them back home was our primary focus. We chose that focus because we felt like if people were being admitted into the hospital, they would have time for, med reconciliation and they would get, care management support. So, but people going back into the community may not necessarily get those additional supports. So that's why we chose that. And we worked 9 to 5. After hours, we also did have a follow-up nurse on our team who we had reports created, and she could pull her report for anybody over the age of 65 that was discharged from the emergency department. And she would just start calling those people the next day. So within 24 hours, they would get a call from our follow-up nurse. If a physician had a particular concern after hours, like our night shift docs loved their team because they knew, that they would just leave us a note on our door and say, hey, would you please follow up with this person? Or, here at Yale now, they will actually hold the patient in ER in like an ED observation status until we come in the next morning to be able to see that patient and hopefully get them discharged back into the community within the 24 hours of their ED obs stay.
Thanks, Pam. I mean, and that's a good example of the capacity building role of the gem nurse, because at our site, at least, and I see many people chiming in that they have several similar protocols in place. At our place, that protocol was developed entirely by Nana, which, until then was this kind of catch as catch can, grab bag. Sometimes you'd hold, sometimes you'd admit. But then once you established a clearly agreed on protocol for how this is going to work and who's responsible for it, which was an activity led by the gem nurse, then it is much more functional. Aoife, an international perspective on that? Your team is not available. Why did you choose to not make your team available through the night?
Well, we had to look at core presenting hours, first of all. So when we were starting, it was a pilot program. We had to prove that it was going to work. We had to prove its worth. So you pick the hours when older people are most likely to present. And that's why we go from 8 a.m. to 6 p.m. But we looked at it. We even tried a pilot one winter of even working weekends or working later into the weekend. And it didn't work because primary care and ambulatory care are not open after hours and they're not open at the weekend. And even, people who were receiving home care in their own home from home care agencies, you can only get them on emergency numbers after hours or not at all. So if we want collateral, if we want to find out at the care agency, have they cancelled this person's call? Are they going in again in the morning? We can't get an answer. So we ended up spending time with patients and actually not being able to help them facilitate a safe discharge because we couldn't get in contact with anybody. So until the community care agencies, ambulatory care works 24/7, we really found that it was difficult to facilitate safe discharges, especially for those who are going home alone.
Thanks a lot. Aaron, do you want there's an interesting question from Switzerland that just came in, which I think might be on everybody's mind. Very last question in the chat.
Yeah. So Anya is asking, do you have any outcome measures for the Geri ED and Geri EM with the nurses or without the nurses? And if not that, what are some of the outcome measures that you may have?
I can start. So we, at my previous hospital, what we did was we used like the hours and days and times that GEMS was available, that the GEMS team was available, and compared that data to the days and times and hours that GEMS teams was not available. And, you know, it was really hard getting data, and it still is. But at that particular time, we did show that we reduced readmissions and 72-hour revisits to the emergency department. We did not show an increased length of stay in the emergency department, which was a huge concern of our ER docs, is that if they consulted us that we were going to lengthen their ED visit stay. And, you know, that's one of the ED metrics that they're counted on. So, you know, that was a huge area for them. And I will tell you right now at Yale, we are actually looking at this data as well. We're just now getting some of the data we need. So we're hoping to be able to share that soon. Right now, we are showing that we decrease admissions. We have not, at Yale, we have not seen a decrease in length of stay. In fact, so.
Good. Aoife, how do you track what you're doing? And that's a big issue in healthcare everywhere. How do you let people know that you're doing good and not doing bad?
Well, when initially with the pilot, the 6-month pilot, the data was looked at before us and after us. So it was looked at, it focused mostly on over 75s and admission rates to the hospital, and also then looked at length of stay in the Medicine for the Elderly Directorate. So after our pilot, there was a big drop in the admission rate of over 75s. There was also, they didn't expect, they thought, you know, that we wouldn't have an impact on length of stay because those who were being admitted really needed to be admitted. So therefore they're unwell, you know, so that they needed whatever length of stay they needed. But it showed actually that those seen by us going to the right bed, you know, if we advocate for the right bed into a specialist geriatric ward, and all our assessments are online, they're on an electronic patient record. So everybody that saw the patient was then seeing them on day 2. There was no repetition of assessments. All of our stuff, all of the assessments we've done in the emergency department count as day 1. That first assessment was planned. And also, even by having discussions with the patient and their carers or relatives in the emergency department, focused on discharge planning from their visit in ED, already in their minds then is, what's the discharge plan? What's going to happen? You know, you're only going to come in for a short stay because we haven't managed to get you home from ED today. And already the patient and their carers are focused on discharge because we were changing the conversation with them. So we definitely decreased admission rates, but we then unexpectedly had an impact on decreasing the length of stay of those that were admitted after being seen by us.
Good. Thanks, Aoife. Michelle, I always had the impression that you were very data-driven at your place. What would you suggest to our audience? What are the key metrics that people need to keep in mind to demonstrate the value of a GEM nurse role?
Sure. So what we did is that I would get a 24-hour report every single day. So I actually really had a good pulse on what was happening the 24 hours before, how many older adults came in. And one of the things it really did, it really showed us who our population is and what we need to do. I could see the percent of people that live alone, the percent that have no caregivers. So when we started seeing that, we said, well, we're going to have to create a senior resource packet, right? So we can help these people navigate the system. I could see how many patients were cognitively impaired, how many people were depressed, how many people came back within a 72-hour admission or 30-day readmit. Why did that happen? So it really gave us a deeper understanding of knowing our population and where we could best serve them. How could create tools to help them stay at home where they want to be. So one of the things that we also noticed too is that regarding transportation, that we didn't really think about this, and you probably thought about this, but discharging somebody in the middle of the night by cab. Hello. Is that the safest thing to do, especially if they don't have anybody there to welcome them? So we had a few things that happened that realized that we really have to think about that, about sending somebody home in the middle of night in a cab. So we created what was called a cab checklist so that these patients, if we did have to send them, that it would actually be safe for them to go home, and or that we called the family, or we would hold the patient back, and or that the patient would call us when they got home, you know, to let us know that everything was okay. But the biggest thing was it's just really, you can really know your population. How frequently how many people were coming in for a fall too? That helped us really concentrate on also fall discharge instruction, getting the pharmacist involved before the patient was discharged to really take a good look at their medication. Could that have contributed to that physiological fall, especially if we were thinking about discharge?
Good, thanks. Another example, several more examples of the capacity building role of the GEM nurse, I think. Nana, when we were talking earlier, you had some interesting comments about team function. Everybody always says geriatrics is a team sport. How can you make this team work if you're lucky enough to have one?
If you're lucky enough to work with great colleagues from social work, OT, PT, even our pharmacist was a bit of a part of the team. And we also had the luck of having a community coordinator who lived, quote unquote, in the emergency department, which gave us really good access to community support. I think for us, despite a well-meaning team, we still, bumped heads and bumped toes because we all do a lot of the same things, but certainly our perspectives are unique and we all bring a different lens. And so part of the getting to a point where we could appreciate each other's lens was really acknowledging that we were bumping heads and, saying out loud the elephant in the room, which was, well, what do you do? Well, what do you do? And so that was the first part, both formally and informally. So we actually developed or had few monthly team meetings where we all came together to review cases, what's working well, what's not working so well. And that really helped us not just to build our team, but also to identify in real time some of the things that we could do to better manage our patient. It also built a lot of trust, because I think that is another aspect of team building. And when you don't trust that the other person is going to, quote unquote, assess the patient as well as you can, and vice versa, that you don't feel that you are trusted to assess the patient. I think some of those tensions started to melt away when people recognize that we all have a common goal and we're all looking to get that patient to the right care in the right place at the right time. And also as team members changed, there was also another opportunity to reinvigorate that process, reconnect and meet and ensure that we were cohesive in our teams, and even social events, like heaven forbid that we went out in pre-COVID, but we would have team coffees, team dinners for birthdays. And that really went a long way to helping us build collaborative relationships as teams. So knowing each other's roles, identifying that we were butting heads, but wanting to move over for a common goal, building formal and informal structures to build out these teams. So we had like an official allied health team group, and just trying to have a bit of fun as teams, because it is hard work, which we also acknowledge, which was a part of why we were also butting heads. So those are some of the things we did. Good.
A phrase I always remember from our team was the no wrong door approach, that it didn't matter whom you contacted. You didn't get pushback. You didn't get say, oh no, that's not for me. That's not an OT problem. It was, okay, I'll take a look. Sounds like it might be more nursing, but I'll check. And if it is, I'll let the GEM nurse know. So I think that kind of free and flexible, recognizing what your teammates are good at, and also how to work with a team is absolutely essential. I'm going to go over to you, Aaron. I think you've got your eye on some other questions.
Don, can I just make a comment while Aaron's looking at questions? So I think, Nana and Aiofe both come from a socialized medicine area, and and in the United States we're fee for service still, and or bundled payments. But I wanted to just comment also, making sure that your ER physicians are a part of your team. Your ER staff needs to be a part of your team if you're not employed by the ER, or making them feel like they're part of the team, and gaining the trust of the ER staff and physicians is a huge. I know Nana talked a lot about building trust amongst your team, but that is also your team, and you're asking them to change their practices. Patients they may have been, admitting, now I'm asking them to discharge, and trust me, to discharge them in the community and not have them come back in 24 hours or 48 hours or 30 days or kind of whatever it is. So taking the time to build that trust. You may have to be selective in your patients that you're choosing when you first start your program, to make sure that you're going to have that success as well. The other thing I wanted to comment on is that the building the trust amongst your team, and this is kind of on me, and it wasn't even a building a trust issue. I just happened to go into the room with my physical therapist, and we were walking a patient together, and I learned very quickly that was not my area of expertise, right? Like she was walking the patient, and I was like, oh, they did great, they could go home. And she was like, Pam, she did not do great. Did you not see all those missteps she just took, like on the way to the bathroom? So we definitely have a very different clinical lens, so utilizing your team is a huge asset if you have one.
Thanks, Pam. Aaron, anything you want to add in here?
Yeah, there's I think I can combine two questions. I know that Susan had another excellent question about transportation, but a lot of times we think about the four walls of our emergency departments, how do you engage with community resources? Obviously with Susan's question with transportation, because these social drivers of health are key pieces. So how do you work with community resources and agencies to enhance disposition for these older adults?
Michelle, do you want to start?
Yeah, sure. So one of the programs that we worked with the community with was with a business that we started a program called the Tuck-In program, where individuals who met certain criteria, that let's say they lived alone, they didn't have anybody, that they would supply the transportation, they would bring them to, let's say, the grocery store, pick up their medications, and then tuck them in and be with them for another 1 or 2 hours. So we developed that program for that population that fit that. Certainly, I've heard other people that had transportation programs that they've actually, hired Uber drivers, right? They had a contract with them. So I'm going to let everybody else speak now what they possibly have done with transportation.
I'm going to move on to Aaron. I think that covers a large part of transportation. I'm going to move on. Aaron, you had another question?
Take myself on mute. Another question with outcomes concerning with patients. I know we talked about 30-day revisits and in the recidivism. Have anyone noticed a correlation with patient satisfaction?
Aoife, why don't you tell us about Ireland's satisfied patients?
Well, basically, it's about asking the patient what matters to them at that time. What do they want? And if they tell you, I do not want to be admitted, then you have to work with them on that to try and bring that, achieve that goal. Obviously, if they're very unwell and they need admission, the hospital is the best place for them to be. But the patients that are very complex, very frail, and that we cannot offer alternative treatment pathways, their therapies or their treatment closer to home. Just taking your hand and telling you, I'm so glad I met you today. Yes, please get me home from here. That's your satisfaction survey. We haven't actually carried out anything official because we feel like it's too it's too early in their healthcare journey to be pinning them down and asking them, because actually when they meet us, it's usually the beginning of their healthcare journey and not the end. They're going on to multiple referrals, multiple inputs, day hospital, community teams, and maybe it would be something to look at. But yeah, the patient telling you, thank you so much, I'm so glad I met you, get me home today, is definitely enough for us.
Pam or Nana, anything to say about patient satisfaction? Do you track it, or is it just a gestalt?
We did track it through Pressgany, is who our hospital system used, and our patients 65 and older did tend to have higher scores, so they were more satisfied with their care through our emergency department. We were not able to track it via whether a GEMS nurse touched them or not, but just, the fact that they were older and came through the emergency department was our only method of tracking.
Yeah, we were unable to track it, but I will say from Effie's experience, it's amazing what people appreciate from a GEM role specific to time, access, and support, which they just don't get in a traditional ED department.
Yes, and our satisfaction scores elevated too, and everybody was telling everybody, and people are coming in, I hear you have a senior ER, that's where I want to go, that's where I want to be put in the emergency department. So eventually we had to change it to, it's this experience, right?
Yes.
It's experience what you're going to receive. It's not just a place, it's the experience, and that morphed over time.
Yeah,
That does bring, go ahead, Nana.
Oh, I was going to say, I concur heavily with that, with people driving many miles just to come to us, just speaking to people, recognizing what they can get out of a GEM role and a GEM experience, and then knowing where to get that experience for sure.
Tess, what do you have to say? You're on mute. You're still on mute. Tess, you're on mute. Tess has been on a Zoom call before.
I can't. There we are. I'm technologically impaired. Okay. So I noticed that in the chat, people were asking about the use of frailty scores and the question of what different frailty scores are used. So if people could address what frailty score they prefer, and then more importantly, how you use that score to help care for the patient. Where in the process? Is it at triage? Is it at discharge? How do you guys handle that? Thank you.
I'm going to send that to Aoife, since I know that your department probably uses the CFS. And how do you integrate it into your workflows?
So we do the CFS ourselves. So we haven't done it I know some places have looked at the triage nurse doing it. But again, the triage it's a time poor experience. They have enough questions to be asking there. They have enough algorithms to answer. And also, unless you're doing the CFS, I mean, it's a good and easy tool to use, but it can be very subjective, and it takes time to ask the patient truly about what their abilities are, what they need support with. And if you don't do it properly and don't give it the time it needs, then you can often get the wrong answer. And it's about how frail the patient is 2 weeks ago, their needs and their supports 2 weeks ago. It's not about how they are today. And that's why we use the Rockwood clinical frailty scale, because giving the patient a frailty score based on how they're presenting now in a crisis to the emergency department, because no matter why they're here, be it for a mental health reason or a physical or functional reason, or being unwell, they are in crisis. That older person is in crisis. So they are not really at their true level of function. And it's unfair to give them a score on how we meet them today. So we always base it on how they were at least 2 weeks ago, and what they're able to do for themselves. And then it's really easy. It's what they need support with. We have it on our patient assessment form, our electronic form. So we give them our score. We then go on to justify that in our notes, why the patient got this score. And it means we can track frailty. I mean, we have notes going back to our patients from 6 years ago when we first met them, and we can actually look at their frailty levels improving or disimproving over the years, and we can follow that journey. And it's then looked at from a referral process. So the most frail, complex people that do need intervention or have a potential to positively impact on their frailty score, we then would advocate, if they need admission, to get a medicine for the elderly bed, because that's where they're going to get rehab. That's where they're going to get work done to improve their frailty. And if they're going home, the most frail patients then tend to need referral to see either a community geriatrician or a geriatrician and team in our day hospital. And it's the frailty score that would help us judge the follow-up and so that the CGA can be completed. We start elements of the geriatric assessment, comprehensive geriatric assessment, in the emergency department, and their frailty score dictates then what we need to focus on, but it also then tells us they need to follow up, they need completion of this assessment.
Thanks, Aoife. Now, as always, we have covered a quarter of the material that we could have done. The chat is loaded with fantastic questions. One that I hoped we would get to was education and training, which seems to be on a lot of people's minds, particularly places that are starting new programs. But Connor, can we go? I would like to just allow everybody to make a few of their most important points before we start wrapping up. Nana, what do you have to say?
All right. And so I think I've sort of highlighted some of these at all levels. So I'll try and say it quickly. So again, incorporating the role at all levels, being involved both with the boots on the ground, but also at the program level and senior organizational levels. That includes finding a mentor or a champion at any of those levels to tell your story as often as you can, whether it be cases or otherwise. Team overlap, we discussed this, and I'll just skip over to the concept that no perspective is not helpful. So focus on clarifying what you bring to the table as a nurse, as a geriatric specialist especially. And then the buy-in and adaptation, and the last piece being that buy-in and adaptation require time and consistency. So again, collecting those cases and stories, sharing them widely, and stories are often more helpful in making change than research, but engaging in research where possible to spread the model, the successes, the opportunities, and also using those research platforms as just a showcase of what you're doing and some of the different things that you are doing to improve the care of geriatrics in the elderly department.
Thanks, Nana. Next slide. I think that's it. The last one is a super important point. Without disparaging the importance and value of research, one story that tells a member of your staff about a good positive outcome that they created will create way more positive change than the biggest randomized control trial in the New England Journal of Medicine. Aoife, what do you have to say?
Well, I think the biggest thing is address what matters most to the patient today. I mean, we often find that why the patient is in the emergency department is a referral from their GP for something that they don't really care about. They've come down, they've been told to get here. And actually it's how they're managing at home is their biggest issue, or that their spouse has been diagnosed with dementia and they can no longer care for them, or that, a child died and they're in despair and grief and can't function and leave the house. So it's about finding out what really matters to the patient today. And it may not always be what they were triaged with, or what they told their GP, or what they told the first doctor that they met. And it's about a conversation with them. The other thing is the luxuries of how we work. And I get that it's not the same as the rest of ED. We are so lucky that we choose the patients that we see. We choose who is most complex, who would benefit from our input most today. So we don't have to see the volume of the same as everybody else in ED. Our day is a much nicer day. And it is about that time and access. So we have access to ambulatory care settings, to primary care, to things in the community that other people don't have access to. And the reason why we have access is because we went and met them. Before we started, we went and had coffee and cake with literally everybody in the community that existed looking after older people. We knocked on their door and said, hello, this is what we want to do, please work with us. And coffee and cake, if you meet someone in person, it is very difficult for them to say no to you over phone or email when you're referring a patient. And again, that's the last point, find out what's in the community. Again, we literally had to map out what's around the hospital, where our patients are living and what they have access to, because the patient geography, their address, where they live may dictate who I can refer to and who I cannot. Then it will change. Me finding out where they live, what their postcode is, will change how I refer, whether it needs to be in hospital ambulatory care, or it needs to be in their own home, and where people live dictates what they get.
Thanks a lot, Aoife. Coffee and cake, it's where it's at in Ireland and everywhere else. And
Yeah.
finally, Michelle. You're on mute. Michelle, you're on
Sorry,
mute. Yeah.
sorry.
I love that time and access point. I preach that all the time. That's kind of our best weapon.
Absolutely. So just I'll do one of the points is community engagement is part of the job. And it doesn't stop at the ER door. So really involve like your pre-hospital providers. They have so much that they want to share and they want to do, and your local businesses. And just to give you a hint, when we went out there and was talking about everything we're doing and why we're creating this setting for older adults and why we want to know what's going on with him, we had local businesses step up to the plate. We had audiology that gave us free hearing aid batteries. We got 2 months free of personal emergency response systems for people that need that medical care alert. EMS came up with this, is that how can we inform the public when they call 911, what did they have to get ready? Did anybody know you have to put your porch light on and open up your curtain windows and corral your animals? Because if that dog runs out or that cat runs out the door, they're not going to go chasing after them. So I really encourage you to be part of get the community involved, because no one can do healthcare alone.
Thanks, Michelle and the whole team. We are now at the hour, so we're just going to click through the last slides. Oh, sorry, Pam. How could I forget our Pam?
I'm just gonna very quickly, gather your team in the beginning, get all your stakeholders involved from the beginning. Everybody has something to contribute. I would encourage you to start small, determine what outcomes you want to impact and how you will demonstrate that. And then just finally, education is not enough. To change the culture in the emergency department. People need to have processes in place, and you also need to share those stories. As Don and Nana said, the stories are going to be your key to success.
Thanks, Pam. Okay, next slide. We are at the time. As we've said throughout the chat, there is a ton of stuff. You were asking for additional resources about many of these observations. There is a ton of stuff on our website. I don't have time to go into them all. Next slide, a podcast by our Pam Martin and Eula. We've done the question and answers. Next slide. This will be available if you come back to the website and under on-demand webinars. Michelle and Aoife put together a fantastic set of resources which will answer a lot more of the questions that you've got. Next slide. And actually we'll present that separately. That's my book, which actually features 3 of the presenters on this call and their work. So it also gives a lot of guidance about developing the GEM role. Next slide. We will be back in just about 8 weeks with a webinar on reframing aging, thanks to the support of our John A. Hartford Foundation and their work in this area, May 15th. Put it on your calendar. Next slide. I think you're aware of how to get to the GEDC. Next slide, please. And thank you one more time to John A. Hartford and West Health. I wish we could go on for another hour, but the most important thing to do is to say thank you to our 4 expert panelists, to all the folks at the support team for the GEDC, Heather and Laura and Connor, and to our chat gurus, Tess and Aaron. And we'll see you back in a few weeks. Thanks for being here, everybody.